All right. So next topic, financing healthcare. How do we get paid? Because it'd be nice after all of this schooling to eventually get paid for it, right? So, the history of healthcare financing is in the early 1900s, most services, including healthcare, was paid for using the barter system. I'll give you a chicken for this. I'll give you a pig for that. Let me fix your horse's shoes for you. So, but as industry changed, people's decreased producing their own goods, but had money on hand and began paying for services, including healthcare. In World War II, there was a need to recruit women to the workforce because all of the men were at war. So health insurance was created as a tool to attract more women in the workforce. So I always thought that was a pretty interesting thing, like how it all started and how important it is for us now. And then in 1965, Medicare was created. We'll talk about Medicare in a little bit. Costs have steadily increased over the year, but skyrocketed during the 1980s. There's a lot of reasons for the increase cost of all of healthcare. Some of those reasons include specialization of medicine. In the 1900s, there was the doc for the community, and that doc might have also been the dentist, and it was just kind of the all-in-one person. We don't have that anymore. Increased use of technologies and the aging American population is a big factor as well. So who finances healthcare right now? Well, individuals. It comes from our pockets, employers, and the government. Now, insurances do not finance healthcare specifically. They just put forth policies and process payments along with assuming the risk. So that's the big thing that the insurances will do, is they assume risk of people. So what does that mean? I think it's the easiest analogy with car insurance. There's a lot of differences between car insurance and health insurance, but broadly speaking, I pay my monthly premium to the car insurance company, and their bet is something bad doesn't happen. They're betting on me being a safe driver. Now, what are some factors of being a safe driver? When is car insurance expensive? So if there's a history, right? So if there's tickets or crashes, increases go a lot. So it's harder to find car insurance, and they're also going to jack up the rates. Why do they jack up the rates? Because your risk is higher, right? So risk in healthcare is use of the healthcare system, and especially when expensive things happen. So, one of the examples, the risk is how likely something will happen. So who has a higher risk of heart attacks, older people or younger people? Well, older people, right? So that's the assumption of risk that those healthcare companies do. Now, the payment process, traditionally, it was a first-party system. So the first party is the individual, us seeking healthcare, pays the second party, the medical provider, whatever that provider might be. Now, there's been an increased use of this first-party system due to, I guess I got tired, due to the increased prevalence of high deductibles. So there's more and more direct pay systems. But the insurance model is a third-party system. So the first party, again, that's the person going to the docs, seeking healthcare, along with the employers or government, pays an insurance company. The insurance company is the third party for their policies. The third party then assumes the role of the administrator and pays the second party. So now it's just a lot more complicated. So we pay this insurance company to pay the other people for us, but they also assume the risk if anything else bad happens. So whenever I talk about, I tried to simplify this topic a lot this week, because one, I don't think we have to tackle this stuff until you start getting closer to practicing as PTAs. But also things change a lot as far as health insurances go. We'll look at some of the changes that happened in recent years. One thing I will recommend, and as you get closer to practicing, I'll recommend this even more. Learn the language of the insurance. Because if you learn the language of the insurance, you can play their game. And if you play their game, you got a shot at winning just a little bit. So the individual that purchased the insurances, the individual pays what's called a premium directly to the insurance company. That's expensive and not very common. So that's that individual purchase. Open marketplace is the common term for that. There could be employer sponsored or group insurance. That's the most common. And recently they've been trying to shift costs away from the employer or government towards the individual. So it's become much more costly for the individual to have health insurance. So just a comparison, in 2009, the employer contribution was around $3,500. In 2019, not too long ago, it increased up to $6,000. All right, so more expensive, but the jump from employee contribution to just under $10,000 a year jumped up more to just 14,500. So more and more shift cost towards the individual. Also the addition of deductibles. So deductibles are the person has to pay the first chunk of payment. And the increasing amounts of deductibles. So when I first started practicing, a $2,000 deductible plan was a high deductible plan. Now, I think it might be termed high deductible, but it is much more common now than it ever was even 15 years ago. There could also be co-payments. Co-payments is a flat dollar amount. You go to the docs, you owe $10. It doesn't matter what the doc does there, you owe $10. Or there could be a co-insurance, which is you go to the docs, you pay 20% of whatever that cost is. So those are some of the languages that we do need to understand. So federal health insurance programs, first up is Medicare. That's the biggest one. Started in 1965 to cover the elderly over 65 years old. There's some other exceptions to that, but for our purposes, we'll just say over 65. There's a few different parts to it. Part A covers inpatient services, hospitals, skilled nursing facilities, some home care. Part B covers outpatient services. That's where most physical therapy will fall under, not all, but most. And then Part D will cover medications. Now, this Medicare Advantage is something that's an optional plan managed by other insurance companies, but they have to follow Medicare guidelines. Boy, that gets really confusing quickly. Really, let's just focus on the Part A, B, and D for us for now. Medicaid, slightly different, started in the 1960s for low-income individuals and people with disabilities. Again, there's some exceptions to this rule as well, but it's easy to think of low income and people with disabilities. That's the easiest way to think about that. And then there's also the Children's Health Insurance Program, CHIP, started in 1997 for uninsured children and pregnant women that fall into this middle range where they make too much money for Medicaid. They don't qualify as low income, but they can't afford their own private insurance either. So that's what the CHIP tries to do, is tries to capture those people that fall into that hole there. So the payment system for indemnity health payments, there's a retrospective or prospective. So retrospective, healthcare provider gets paid after the service was provided. This is the traditional method. We have some options that are moving away from this, but this is basically what it is. I treat a patient for physical therapy, and in a month, I hope to get paid by the insurance company. And they're going to screw something up. They're going to say it was a mistake, but it never is. And then I hope to get paid the following month. So there's a big lag time between when I give services to when I get paid. Typically this is used for fee for service, which is I'm going to bill for every single item that I provide. So if I do 15 minutes of exercise, I bill for 15 minutes of exercise. If I do 30 minutes, I bill for 30 minutes. The costs are controlled and required to be usual and customary and reasonable. So I can't just say, you know what, this patient's a pain in my neck. I'm going to charge them $15,000 for being here just because I'm annoyed by them. The insurance is going to say, well, that's not usual and customary. And I'm going to say, but the patient's not usual and customary. They're going to say it doesn't matter. So there are some cost controls, but just by reading this, so the fee for service, I'm billing each item provided. So in the hospital sense, it would be, we are going to charge the insurance company for every single pill of Tylenol we give you, for every single blood draw we give you, for every single x-ray we give you. We're going to bill the insurance every single time. Now, if I want to make them a lot of money and I don't really care about the patient, what does that process incentivize me to do? Do more things. Whatever the things are, do more of it. As long as it's usual, customary, and reasonable, the goal is to make the bill as high as possible so I get paid the most, right? So that is some of the problem, and that adds to the complexity of some of the healthcare costs, is when we incentivize people to do more. All right, so recently there's been a prospective method. The healthcare provider gets paid in advance of providing care. Now, there's a lot of ways to figure out how much we're going to get paid. The biggest thing is by the insurance uses this diagnostic related group. So for someone of this age with this diagnosis, total knee replacement, the total cost should be $15,000. So here you go, surgeon, here's $15,000 and fix the patient. Surgery, physical therapy, medications, whatever it is, you got it. But you got to figure it out. Here's 15 grand. So now what does that incentivize the healthcare provider to do?
Keep it with under.
To try to spend as little money as possible, because the less money we spend on providing care, the more profit we get, right? All right, so if in terms of controlling cost, all right, we're incentivizing the providers to really be efficient. If you're the patient, what do you think? It's kind of incentive just to kick someone out early, discharge early. And one of the things that I always hate about this is there are things that those diagnostic related groups don't measure that really impact the patient care. Level of education is one of them. Where do they live and how many people they live with? The patient might not smoke, but everybody else in the household does. That is going to negatively impact that patient's outcomes and how much their healing time just from being around that secondhand smoke. So it's got its own, that prospective method also has a lot of problems. Also, sometimes patients just get infections. Sometimes they fall. Sometimes bad things happen that's just not up to us. So you can lose money on a case really quickly if one of those bad things happens. So when the insurance company is supposed to, the benefit of the insurance company is they're supposed to be taking the risk. Now, where's that risk shifted? Now it's shifted kind of back towards the providers too, right? So there's another thing called managed care. So the Health Maintenance Organization Act was passed in 1973, allowing companies to manage care in two major ways. One, using a predetermined payment schedule, which is a discount fee, and using a provider network. So here's how this works. Blue Cross calls me and says, Josh, I know you're a physical therapist. You want access to our patients. So I said, I love Blue Cross patients. In Rhode Island, it's Blue Cross and United Health are the two biggest insurance providers. So if I'm going to have access to those patients, I got to play their games, right? And they're going to say, okay, Josh, I know you want to get paid $100 a visit, but we're going to pay you $70 a visit, but you get access to all of our patients. Now, it's up for me to to determine if that's a good deal for me or not. So that's how the provider network works. Now, there's a lot of different versions of HMOs, HMOs specifically, PPOs. I didn't want to go into all of that stuff because I'm falling asleep just talking about it. And by the time you guys graduate and start practicing, all of these things are likely to change anyway. So I didn't really want to spend too much time on it. Just understand that the big thing with managed care is the provider is accepting a discounted rate for being in the network. And the patients are incentivized to use in-network providers as well. But all characteristics of different versions of HMOs share some sort of in-network versus out-of-network costs. So some also put limits on number, in the PT world specifically, puts visits on number of visits allowed per year. We'll give you 12 visits a year. We'll give you X amount per injury. So that's some other ways that the managed care can happen. So other payment trends is consumer-driven health plans. So these are high deductible plans with health savings options. These, in my opinion, are skyrocketing in their prevalence in our general population. So there's a reason that can be good. I'll talk about it a little bit later. Value-based healthcare, which is a range of initiatives to attempt to reduce costs while also improving patient outcomes. So the insurance companies will pay us more if we give quality care. This requires evidence-based medicine, patient satisfaction. Also, it removes incentives to perform more and more procedures, like that fee for service that we just talked about, how it incentivizes us to do more. This value-based care incentivizes us to do as little as possible, but still getting good patient outcomes. So where the prospective method just says, here's the money, do whatever you want, and we just hope the patient gets better and is happy, this is a little bit more aimed towards patient outcomes. Now, I will tell you, the one thing I hate about this is this patient satisfaction part of it, because I think now we can be starting to make poor decisions just to make patients happy, when there's some problems with that. There's some good things about it, but there's also some problems with it too. Because I'll tell you one story. I sent my patient to the best shoulder surgeon I know. But the guy can, if you catch him on the wrong day, he's kind of a jerk. But he's the best surgeon. If I had to have shoulder surgery, I'm not going to anybody but this guy, right? I don't care if he's a jerk. Patient gets a great outcome, great surgery, great PT, because I'm great too. And how it's the patient satisfaction though, just because the guy was kind of a jerk the 2 times that he saw the surgeon. It's the patient's going to say on their satisfaction ratings on the quiz, on the little survey, poor just because the guy was a jerk. Yeah, but your shoulder works now. Who cares if the guy was, if you're happier, like that the guy, you're not going to be friends with the guy anyway. Like your shoulder works. Think about that. So I think there's some things left to be desired for the patient satisfaction. It's a good measure in some ways, and others it can be really problematic. So some general enrollment trends. Employer-sponsored health insurance covers about 153 million people in the United States. So that's right around half the population, not quite half the population. 44% PPO, again, that's one of the managed cares, 19% HMO, again, a managed care, and then another 30% with a high deductible plan with a savings option. Now, that again has grown a lot. Now, what is great for us for that though, is there's a shift towards cash-based practices avoid insurance reimbursement altogether. This time of year, so insurance is generally reset January 1st. So if you have a $3,000 deductible and you haven't met any, I haven't been to the docs this year yet, right? So if I got a big deductible, but now I go into my car and I break my leg, All right, well, that 3 grand I've got to pay out of pocket. It's all going to reset at January 1st. I'm going to have to pay another 3 grand come January 1st. I can go anywhere I want. I don't have to be in network, out of network. I'm just paying cash anyway because I'm going to have to pay all this deductible anyway. So there are some practices that I have 2 friends that have just cash-based practices. They do not use insurance whatsoever. That's pretty great. I think there's some real good benefit to that. There's some problems with it, but there's some real benefit to that. Some other things that, one of the things we have to do is PTs and PTAs must be knowledgeable about the insurance plans and those benefits of those plans. Your insurance plan only gives us 12 visits a year. We're only going to use 8 of them right now. Well, we hope to only use 8 of them right now because we want to save some should something happen. Your insurance plan is going to reset January 1st. We're going to use all of these right now because come January 1st, we're going to get another 12 or we're going to use them then. So all of that is really important for us to know. And it's an unfortunate part of the job that we do have to do. But there's a big shift in value, improving patient outcomes in the shortest time possible. So being really good at our jobs is important and not getting lazy. And if I'm going to be critical of some PTs and PTAs out there, let's not get lazy. The patient should not be doing the same treatment 2 weeks in a row. The patient is changing. They're either getting better or getting worse. And if they're getting better, the treatment should keep up with them in order to keep them progressing along. If they're getting worse, we miss something and we need to catch that right away. My big pet peeve that I see of some clinicians is you've been seeing this person for 2 months and you haven't changed their exercises in 2 months. That's insanity to me. So big shift to value. Let's be on top of it. Let's actually be engaged in our work and not just mailing it in. That is important.
Well, obviously you say that the assessments and all that, but
Yep.
how is the time period for the fee towards switching up their work?
So the question is, how frequently should we make modifications within their treatments? As much as every day, every visit. And I would there's some factors that patient satisfaction matters. So if they come in complaining that their exercises were too hard last time and their legs are sore, yeah, but does your back feel better? Like we need to build strength here. So there's some skill of teaching the patient. I think most of our patients are going to get better pretty quick, and we need to keep up with them and to keep them progressing along. There's an art to it as well. So what I always say is this physical therapy, physical medicine, as much science as it is art. So there is some art to it. And maybe for my really nervous patients that are finally seeing progress, maybe I hold off on making changes right away because I want them to just be happy that they're making progress. Yeah. So there is an art to it. What I will say, the art is not having the patient do all the same treatments, every single exercise is the same and unchanged for 2 months in a row. That's anybody that does an exercise routine right now, have you changed your exercise in some way in the last 2 months? Yeah, of course. The weight's different, the tempo is different, the distance we run is different. Like something has changed. If it's not, we're not what? Improving, progressing, right? So same thing for our patients. There's no different there. Yeah, so it's just something I'm critical of, and that, with the shift towards value, how do you get the patient best, fastest? We need to be really good and engaged in what we do. Yeah.
Well, like if you're asking to like exercise and then want to see how they do the exercise beforehand and see if they're getting good or better, can you do that too?
Of course, yeah. We're always going to be assessing our patients in everything we do, and it might be that's any of the tests that we talk about this year, and it could just be, hey, I want to play with this exercise for now. I think next week you're going to be ready for it, but let's see how this deep squat feels. What do you think about that? Yeah, there's always things that we can do to look at that and see how they're doing. Yeah. Do we have any other questions about financing? Yeah.
Heard that, PTAs can run their own cash-based practice, is that correct?
Can PTAs run their own cash-based practice? Knowing what you guys know, what is the answer? No, why? We can't do the examination. So no, it does not matter. It is a law that the physical therapists have to examine the patient to evaluate the patients. There is nothing stopping a PTA from owning their own business, as long as a PT does the evaluations. I know of one PT that owns his own practice, owns an outpatient physical therapy clinic. So it can happen that, but you cannot treat a patient without that physical therapist examination first. Yeah. All right, any other questions?
You were talking about how